manipulation, rationalization, rage, avoidance, hopelessness, or projection. Shame-informed therapy is continuously searching for hidden core shame and the defenses against it. It is only when the clinician begins to see the client through the fine-tuned lens of shame that it becomes more evident how most of these symptoms could represent a defense against shame. Core shame is so painful and contagious that the witness to shame often looks the other way. Therapists are no exception. The origin of the word shame means to cover. A client's unconscious shame can be so powerful that the therapist can get caught up in the projections and thus feel inadequate to the task. It is important for shame-informed therapists to look at their own unconscious experiences of shame-proneness in order to better tolerate and co-regulate with clients. Early shame researcher Helen Lewis called shame the sleeper emotion because it is not easily recognized, and she proposed that when therapists fail to recognize core shame as a critical aspect of treatment, problems worsen. When the therapist doesn't have fine-tuned empathic listening skills, which are needed to identify core shame, clinical interventions can easily trigger more shame, spiraling the client into other affective experiences, such as embarrassment, guilt, or obsessive worry. In contrast, when clinicians understand how shame influences the therapeutic relationship, treatment is more effective, as clinicians can then build more sustainable strategies that improve treatment outcomes. Creating authentic relationships with clients and trusting the individualized process allows clinicians to step more fully into unconditional positive regard. This process allows the client to feel good enough as the therapist sees into and feels the client's experience with empathy, which is the antidote to shame. Core shame erodes the ability to recognize what Donald Winnicott labeled the true self, or the essence of what one has been born to be. Instead, a false self emerges, and in an attempt to feel lovable, clients create stories about themselves based on what others have suggested they become, or they develop faulty coping mechanisms. That is, the false self develops based on what others want. It overconforms and only loves conditionally. It hides, covers, or denies feelings. Shame-informed therapy offers tools that help clients excavate their true self as they begin to recognize the defenses against core shame they have developed over time. This involves integrating the right and left brain functions, as well as regulating the autonomic nervous system in order to reconstruct a more authentic self. Through this lens of reconstructing the authentic self, this workbook seeks to provide a framework for treating core shame in clinical practice. It provides some guidelines that help clinicians excavate the origins of shame and better identify the nonverbal, unspoken, and unseen aspects in their clinical work. It is intended for mental health professionals who work with clients struggling with anxiety, depression, mood disorders, relationship difficulties, or chronic low self-esteem. However, the exercises in this book can be helpful in other circumstances as well, as core shame is a universal human experience. What is in this book? The workbook is divided into 2 parts. Part 1 helps clinicians look more closely at the therapeutic process from the very fine lens of shame-informed therapy, providing an overview of early shame research and current neurobiological findings, illustrating how core shame gets wired into the brain and nervous system. It also discusses the stages of building and maintaining a therapeutic relationship characterized by empathy and safety. Part 2 provides a multimodal approach for working with right and left brain co-regulation and the autonomic nervous system in therapy. This approach integrates Stephen Porges's 4 therapeutic R's. 1. Recognizing the autonomic state the client is in. 2. Respecting the adaptive survival response. 3. Co-regulating with the client into a state of safety. And 4. Restorying. With other bottom-up and top-down psychotherapy approaches, creative arts, metaphor,